Hello everyone, welcome back. Today I'll be covering Acute Respiratory Distress Syndrome, ARDS, a basic science topic. This includes introduction, ARDS heterogeneity, ARDS criteria, predisposing and risk factors, pathophysiology, clinical features, management. Now let's get started. Introduction. ARDS, Acute Respiratory Distress Syndrome, also known as Acute Respiratory Failure, Acute Lung Injury, Shock Lung, Respirator Lung, Pump Lung, Danang Lung. ARDS is a diffuse lung injury caused by intrapulmonary and extrapulmonary factors in a short period of time, histologically characterized by diffuse alveolar damage, including pulmonary edema, hyaline membrane formation, alveolar hemorrhage, and inflammation. ARDS heterogeneity. The clinical, physiological, biological, and imaging manifestation of ARDS are highly heterogeneous. The etiological factors of ARDS can be divided into two types, intrapulmonary and extrapulmonary. The intrapulmonary factors, such as pneumonia and mechanical ventilation, primarily inflict damage on the alveolar epithelium, whereas extrapulmonary factors like sepsis and acute severe pancreatitis initially impair the endothelium and subsequently result in pulmonary edema. ARDS clinical syndromes. These include acute respiratory failure, severe hypoxemia, PaO2 to FiO2 less than 200 mmHg, bilateral infiltration on chest X-ray, stiff lung CT less than 50 ml per centimeter of water, POP less than 12 to 18 mmHg, and there is a predisposing factors. Berlin definition published in 2012 defined ARDS according to the PaO2 to FiO2 level. The new definition, oxygen saturation SpO2 to FiO2, is allowed to replace the PaO2 to FiO2 in the classification criteria. This table shows the Berlin definition and the new global definition of ARDS. For Berlin definition, disease onset, existing clinical injury, or exacerbation of new or existing respiratory symptoms occurred within 1 week. The pulmonary imaging findings. The X-ray or CT scan show a bilateral dense shadow of the lung that cannot be explained by effusion, lobar pneumonia, atelectasis, or nodules. Oxygenation index. Mild, around 200 mmHg, less than PaO2 to FiO2 less than 300 mmHg, with PEEP to CAP more than 5 cm of water. Moderate is around 100 mmHg, less than PaO2 to FiO2 less than 200 mmHg, with PEP more than 5 cm of water. The severe is PaO2 to FiO2 less than 100 mmHg, with PEP more than 5 cm of water. The new global definition. The onset of COVID-19 cases may be prolonged. HFNO was included to capture those with a slow course of disease. Then in addition to the bilateral opacities on the chest X-ray and CT, the absence of ventilation identified by ultrasound can be used as the criteria. In addition to PaO2 to FiO2, SpO2 to FiO2 can also be used for severity assessment when SpO2 less than 97%. A new category of non-intubated ARDS was created for patients with HFNO more than 30 liters per minute who met the criteria for ARDS, and PaO2 to FiO2 and PEP were no longer mandated as a limited condition criteria. Okay, everyone? The causes and risk factors. Common risk factors are pneumonia and non-pulmonary sepsis, followed by aspiration of gastric contents. The trauma and blood product transfusion are less common ARDS risk factors in the modern era as ventilator, fluid risk, and transfusion management is better. Common precipitants. Pneumonia, bacterial, and viral are the most common, whereas fungal, mycobacterial, and parasitic pneumonia are less common. Non-pulmonary sepsis, aspiration of gastric contents, and pancreatitis. Take note. Another common precipitants is non-cardiogenic shock, severe trauma, or high-risk surgery. Example, esophagectomy, drug overdose, ischemia, reperfusion injury. The less common precipitants: smoke inhalation, drowning, e-cigarette or vaping product use associated lung injury, EVALI, multiple transfusion of blood products. Diagnosis not typically classified as ARDS: vasculitis, diffuse alveolar hemorrhage, drug-induced pneumonitis, organizing pneumonia, hypersensitivity pneumonitis, acute eosinophilic pneumonia, acute exacerbation of interstitial lung disease, acute chest syndrome, that is sickle cell disease, alveolar proteinosis, malignancy. Pathophysiology of ARDS involves two phases: A. Exudative phase, B. Proliferative phase. A. Exudative phase, usually 24 to 96 hours after injury. Resident alveolar macrophages are activated, leading to the release of potent pro-inflammatory mediators and chemokines that promote the accumulation of neutrophil and monocytes. Activated neutrophil further contribute to injury by releasing a toxic mediators. The resulting injury leads to loss of barrier function as well as interstitial and intra-alveolar flooding. Tumor necrosis factor TNF mediated expression of tissue factor promotes platelet aggregation and microthrombus formation as well as intra-alveolar coagulation and hyaline membrane formation. To simplify, all this leads to endothelial damage and damage to the alveolar type 1 that leads to impaired surfactant production and function. Alveolar and interstitial edema occur. This figure shows the healthy lung and the exudative phase of ARDS. We can see there is an injury due to bacteria, virus, fungal or trauma or gastric contents, etc. So the injury caused the alveolar macrophage to be activated, and this will stimulate the inflammatory like macrophage that secrete T cells to necrosis factor, interleukin, etc. So at the same time, this will cause the endothelial injury leading to the release of biomarkers of endothelial injury, VEGF, angiotensin, vascular coagulation leading to platelet aggregation and microthrombi formation. And there is an endothelial barrier disruption via activation of the actin-myosin contractile apparatus. So this interstitial flooding will cause a accumulation of edema fluid, and there's a formation of hyaline membrane along the denuded basement membrane or lead to the damage to the basal membrane. For proliferative phase, day 3 to 7 of event, there is type 2 cells, alveolar space filled with cells. There is organization of hyaline membrane, microthrombi, and platelet aggregation. After day 7, fibrosis of hyaline membrane, reparative process by type 2 cells. This causes irreversible pulmonary fibrosis. This figure illustrates the ARDS phases. For the exudative phase, after the cell injury, there's an injured alveolar capillary barrier, increased permeability, edema fluid accumulation, inflammation cells recruitment, whereby the neutrophil will predominate. There is a reduced space for gaseous exchange, breathing difficulties, and assisted ventilation is needed via mechanical ventilator. For proliferative phase, there's a proliferation of type 2 cells. Type 2 differentiate into type 1 cells, lymphatic drainage of edema fluid, recovery of alveolar capillary barrier, edema fluid resorption. Patient will feel better. Mechanical ventilation might not be required. Most patients recover in this phase. For fibrotic phase, very few progress into it. There will be a fibroblast proliferation, increased fibrosis. There's an increased pulmonary hypertension. This is poor prognosis and ventilator-dependent breathing. Diagnosis. The diagnosis of ARDS is often clinically challenging because of non-specific features of this condition. ARDS mimics include cardiogenic pulmonary edema, acute eosinophilic pneumonia, acute interstitial pneumonitis, cryptogenic organizing pneumonia, and diffuse alveolar hemorrhage. Lung biopsy has been reported to change the management in 60 to 80% of selected cases in which the diagnosis of ARDS remains uncertain. Importantly, lung biopsy is reserved for a minority of patients in experienced centers because of its high rate of severe complication, around 10% in a critically ill patient. The first chest X-ray shows the vaping-associated lung injury with pneumomediastinum arrow. The second chest X-ray shows a SARS-CoV-2 infection causing ARDS. Management is non-specific treatment, mainly supportive. The aim of the management is maintaining a safe PaO2, maintain circulation, treat underlying causes, prevent complication. Maintain safe oxygenation with saturation more than 90%, PaO2 more than 60 mm mercury, FiO2 less than 0.6, MAP more than 60 to 70 mm mercury. Maintain circulation. Keep beat on a dry side with CBP around 8 to 12. Maintain cardiac output, CO. Urine output more than 0.5 ml per kg per hour and avoid overload. The methods: mechanical ventilation. Respiratory support with a mechanical ventilator is a double-edged sword that can also exacerbate lung injury. Causes of ventilator-induced lung injury, VILI, is 1. Volutrauma or barotrauma. Delivering too much volume or pressure leads to overdistension of alveoli. Because the compliance has been delta volume, so delta pressure of the ARDS is heterogeneous, the same airway pressure may cause underdistension of a more affected lung region with low compliance and overdistension of a less affected region. The causes of ventilator-induced lung injury, VILI. Again, 2. Athlete trauma, allowing a alveoli to collapse completely during each breath cycle with too little airway pressure leads to shear stress and denaturation of surfactants. 3. Biotrauma. The physical force and trauma of the ventilation leads to release of mediators that sustain inflammation and translocation of pro-inflammatory products and bacteria through all already permeable barriers, causing a systemic damage. This figure shows the lung injury caused by forces generated by ventilation at low and high lung volumes. A. Ventilation at low lung volume cause athlete trauma and lung inhomogeneity. Ventilation at the high lung volume causes hyperinflation whereby overdistension occurs and air is leaked. Structural consequences: there's a sloughing of bronchial epithelium, epithelial mesenchymal transformation, surfactant dysfunction, fibroproliferation, increased alveolar capillary permeability, pulmonary edema, and biologic alteration include increased concentration of hydroxyproline, transforming growth factor beta interleukin beta, release of mediators such as tumor necrosis factor alpha, interleukin 6, interleukin 1 beta, recruitment of pulmonary alveolar macrophage, neutrophils, activation of epithelium and endothelium. All this will cause an increase in physiological dead space, decreased compliance, decreased PaO2, increased PaCO2. Systemic effects include translocation of lipopolysaccharides, bacteria, various mediators, that multiple mechanisms will increase apoptosis and multi-organ dysfunction, and finally, death. Techniques of ventilation. Low tidal volume ventilation. In 2000, the landmark ARMA trial, also known as ARDS NET trial, showed that a ventilation strategy with tidal volume of 6 ml per kg of ideal body weight and applied to pressure less than 30 cm water resulted in a lower mortality rate. Keep the PIP less than 35 cm of water, high PEP more than 15 cm of water, lung recruitment or open lung technique, prone position. This improves ventilation and perfusion around 6 to 12 hours, permissive hypercarbia. Treat the underlying causes with antibiotics, surgical management, steroid. 2 mg per kg for 2 days BD dose, 1 mg per kg times 7 days OD dose, 0.5 mg per kg times 7 days OD dose after 7 to 10 days of diagnosis. In 2020, the DEXA ARDS trial demonstrated a 60-day mortality benefit in mechanically ventilated patient receiving a dexamethasone 20 mg IV intravenously for 5 days followed by 10 mg for another 5 days. Patients receiving dexamethasone also had more ventilator-free days. Prevent and treat the complication. These include stress ulcer, malnutrition, pulmonary hypertension, sepsis, prolonged intubation-related DVT prophylaxis. Other therapies. This includes steroid, as discussed before, ECMO, extracorporeal membrane oxygenation, surfactant, reduce atellate trauma, Prostaglandin E1, improve VQ, ventilation perfusion mismatch, anti-endotoxin antibodies, bind endotoxin and thereby reduce inflammatory response, nitric oxide NO. Inhale nitric oxide can decrease the pulmonary vascular resistance locally in ventilated areas of the lung and shunt more blood to the area, thus improving the VQ mismatch and oxygenation. Yay, we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.